So going to the bathroom, urinating a lot. So diabetics that urinate a lot, they're losing electrolytes. Burns also is also going to cause fluid loss because you're losing part of your skin, and so again, capillary leaking is going to cause blood loss. So there's ways that we're losing. So that's the inadequate volume part of shock. Now, as far as the pop goes, so here's the heart. And we know that the electrical impulse starts at the SA node and it works its way down, right? It goes through, goes down and up and around. Kind of a weird smiley face, right? Well, we have an area of the heart. That dot represents dead tissue from a heart attack. So again, as the impulse is traveling down, it gets to that dead spot. It can no longer keep going that way. It can't keep going down. So what it does is it diverts it. And then it's able to do what else it needs to do. So normally we have the muscle contracting, right? But if that part of the heart is not getting an impulse because it's dead, is the strength of the contraction still hard enough to push what it pushed before?
No.
So how well or what's going to happen to the perfusion now?
Decrease.
It's going to decrease because, again, due to that pump problem, the heart is not strong enough anymore to continue its normal job. And that's what can happen to heart attack patients. They can develop, depending on where on the heart and how much damage there is, will cause them to have what we call heart failure. And that's something else that happens too. And we'll talk about that with cardiac emergency some. But that's what we call heart failure. And so because the heart's no longer able to push out as strong as it did, is all of that blood that was in the ventricle going to get pushed out?
No.
Okay. So we know so here's the heart, here are the lungs, right? The blood comes back from the lungs into the left atrium, correct?
Yeah.
And so that's blood, that represents blood that gets sent through. Which valve is that?
Mitral.
The mitral valve. And it goes here into the left ventricle. The left ventricle then is going to push it out the aorta to the rest of the body. Well, if not, if all the blood did not go out, so that's backup of blood. And so eventually that blood starts backing up. So it's not able to push out enough blood out of the ventricle. Where's the blood backing up into now?
The lungs.
Okay, eventually it's going to be in the lungs. Yeah. It's going to back up into the left atrium. And then that in turn is going to back up into the lungs. So you see the blue in the lungs? What do you think that represents?
Fluid.
That represents fluid. And yesterday, yeah, you guys did lung sounds, right?
Yeah.
Yes.
Which lung sound represents fluid in the lungs?
Wheezing.
Nope. That's
Crackles.
bronchoconstriction. Crackles. Crackles represent, I was going to say crapples. Crackles represents fluid in the lungs. And that's because the pump is failing. All right, that's why when you hear it, it sounds like popping, like you're blowing air into a glass of water through a straw. So you have that cracking sound, that crackling, popping sound. Okay. All right. So pump function. Now the other thing about pump, again, it might originate in the heart, or it usually is originating in the heart. Something's wrong with the pump. And that's not necessarily from an injury, although there are injuries that will cause a decrease in pump function. But a lot of times it's because of age. As we get older, our arteries start to become thicker and our heart muscle becomes weaker. I mean, look at Schwarzenegger. If you ever saw the original Conan the Barbarian, or even Terminator, you remember how buff he was?
Yeah.
And how buff is he now?
He's not. Well,
He's not.
he used to take steroids too, so.
Yeah, but let's ignore that fact and just say, remember how muscular he was?
Yeah.
But you're right, and a lot of them did it back then. So
No,
even
but he did
too.
a lot of muscle mass too.
Yeah, but look at over age. He doesn't have the same biceps. He's lost a lot of muscle tone, and that's what happens to all of our muscles, including the heart, because the heart is a muscle. Remember, so it becomes weaker over time. That's just a normal part of aging. Okay. All right. All right. We talked about the vessel tone. So, if the blood vessels become really constricted, I'm sorry, dilated, that's going to reduce the amount of perfusion through. But the other thing is, and we'll talk more about this in a little bit when we talk about neurogenic shock, is that what nervous system controls vasodilation and vasoconstriction?
The nervous.
Okay, but which component of the nervous system?
Cervical.
The sympathetic.
All right, the sympathetic nervous system. The sympathetic, but also the parasympathetic, right?
Yeah.
So
Yeah.
it's kind of the autonomic nervous system, sympathetic, parasympathetic. All right. So the sympathetic, excuse me, the sympathetic nervous system is going to cause the blood vessels to do what?
Isn't it to maintain resistance and pressure?
Okay. So what are the blood vessels going to do?
Dilate.
Dilate.
No, not sympathetic.
Constrict for the sympathetic.
Constrict.
Dilate
Yes,
for the-
sympathetic, they're going to constrict. And The parasympathetic, they're going to dilate. Remember, it's bringing you back down to normal. So just remember that for when we talk about it. All right, as far as okay, as far as categories of shock, this is just a broader category. So the easy way to remember, do you remember why I taught you, Miss Rosie?
Which one?
For the categories of shock?
Is it um I know the ones with the heart can't get it on the top of my head right now.
Cardiogenic.
Remember docs?
Obstructive. Isn't obstructive and something like that?
Uh-huh.
Hypovolemic, destructive, cardiogenetic, and obstructive.
Distributive, so DOCH. Obstructive, cardiogenic, hypovolemic. Okay. DOCH, DOCH, distributive, obstructive, cardiogenic, and hypovolemic.
Go to the bottom. C. I got it.
You guys got it?
Yeah.
Distributive, obstructive, cardiogenic, hypovolemic. Okay. All right, so let's talk about hypovolemic first. So hypovolemic, the term itself means low volume. It is used, excuse me, it is used interchangeably with hemorrhagic shock. In a way, they're both the same. Hypovolemic, low blood volume, hemorrhagic, loss of blood. But generally hypovolemic, low volume, whereas hemorrhagic shock is they're bleeding out. Now, the most common type of hypovolemic shock is hemorrhagic shock. But we talked about burns and dehydration as well. They could also cause hypovolemic shock because they're losing volume. And we'll get into the causes in a little bit, but just starting off with hypovolemic. low volume or low blood volume. All right, next up is distributive shock. What you have to remember, or the way to remember distributive shock, is it's a distribution issue. It's some sort of distribution issue. So volume goes down. The blood vessels can't constrict, so they're dilated. So what's happening to your blood pressure?
It increases.
No,
Mm.
it's
And
going to
it
decrease.
Decreases.
Again, the loss of volume, but increased, you have vasodilation, there's going to be less stretch. So your pressure's going to go down. And so remember, less systemic vascular resistance, there's less stretch on those arterial walls. So your blood pressure is not going to be high enough. So it's
Hey,
still
Luis,
distribution.
you said the blood vessels, they dilate, or did you
Yes.
say that? I didn't hear you cut off.
Yeah.
Okay.
So when we get more specific, we'll see where that comes into play. But yeah, you have massive vasodilation, but your container changes, but your volume doesn't. So again, distributive shock is a distribution issue. Let me do obstructive shock real quick. Obstructive. The way to think about obstructive shock is it's an obstruction, some sort of obstruction that's obstructing the blood flow. So while distributive shock is a distribution issue, obstructive shock is an obstruction that's blocking the flow of blood. So a blood clot is a type of obstructive shock. Tension pneumothorax, where there's increased pressure within the chest cavity that's causing an obstruction of blood flow. So something is causing that blood flow to be obstructed. And the last one's a pericardial tamponade, which just means that there's bleeding within the sac of the heart that's putting pressure on the heart itself, so it can't pump out the way it normally does. So again, there's an obstruction somewhere along the way. Then you have cardiogenic shock, which just means, oh, is that a baby shepherd? Amber?
Yeah.
Oh, they're so adorable at that age, but they grow up too quick and then they push you around.
Yeah, he's still too baby. He doesn't listen.
Jeez. Aren't they adorable? They need to have more miniature cats so that way the kittens, when they grow up, they still stay small and adorable. Once they grow to be adults, they're real big assholes. Sorry. All right. So cardiogenic shock, like in Genesis. So it's originating in the heart. So cardiogenic shock starts in the heart. Holy cow. Cardiogenic shock originates in the heart. So something is causing the heart not to function appropriately, correctly. And we're talking about that heart failure. A heart attack will cause that heart failure. All right, and the last one they talk about, metabolic or respiratory shock. When you have metabolic or respiratory shock, that's just the body's inability with the diffusion of the oxygen and carbon dioxide in the blood. So remember, if you have too much carbon dioxide, yes. Rosie's getting me all dizzy.
My bad.
I just see you going like what is she doing?
I thought you had like the PowerPoint.
No. I don't want to bore you with PowerPoints.
He's going off of it. Like
Huh?
So he's going off of it. Some of it he's talking about.
No, I have the lesson plan.
No, I know, but like it's some of it. What you're talking about is on the what the PowerPoint is talking about too.
Yeah. But I got the lesson plan too. So anyway, metabolic or respiratory shock. The body's inability to diffuse oxygen into the blood. So anyway, the main types we're going to worry about are DOCs. Distributive, obstructive, cardiogenic, and hypovolemic. Okay. All right. Oh, the only thing I don't get here is that they give you the categories and then they get in this specific type of shock. It's like we already did that, but kind of sort of. So like I said, a hemorrhagic shock is they're bleeding out. Something is causing the blood to leak out. Usually blunt trauma or penetrating trauma. If you take, and it's kind of like that paper bag injury we talked about, if you compress an organ, it can rupture. And being vascular, it can leak out. Same thing with the uterus. Okay. A puncture, a gunshot wound, or a stabbing to the thigh. That's going to cause bleeding. So hemorrhagic shock, we're losing the most important thing we need, which is blood to carry that oxygen. So again, what do you think the treatment needs to be?
Blood transfusion.
Yeah, blood transfusion. They need to give them blood to be able to transport that oxygen. Okay. The good news about bleeding, hemorrhagic shock, or about bleeding is that all bleeding eventually stops, right? The bad news about bleeding is all bleeding eventually stops. We run out of it. But the body's going to go into shock after 15% blood loss. We'll start seeing the early signs of shock after 15% blood loss or stage 2 blood loss. Okay. Another type of hypovolemic shock would be, again, losing electrolytes, losing water, losing plasma. Because we're losing volume, again, our pressure goes down. In that case, fluids will help a hypovolemic patient. So as we were talking about earlier, somebody's dehydrated. That's hypovolemic shock, is it not? From whatever reason.
Yeah.
They can get fluids to rebuild that pressure back up. Man, it sounds like all the smoke detectors are going off. They all need battery replacements. Uh, uh, um. All right. Another type of hypovolemic shock would be burn shock. So we were talking about burns, how it's affecting the skin. It's also damaging the integrity of the capillary. As a result, volume is getting drawn out of the cells into the interstitial space. You guys remember the interstitial space and the intercellular space? So the interstitial is the area between the cells. And so that's going to cause swelling. So blood loss, swelling because it's getting stuck there. So with burns, we have to be careful. So let me back up a little bit. So we haven't covered this yet. We'll cover this in soft tissue injuries and burns. But one of the dangers of suffering an airway burn is because that airway can swell up and shut down or be closed off. And it's exactly for this. Number one, understand that traumatized tissue swells, period. Whatever it's causing it, traumatized tissue is going to swell. If you inhale hot smoke, superheated gases, whatever the case may be, did you just damage the outermost layer?
Yeah.
Yes. So now, are you going to have capillary permeability?
No.
Well, you're going to have leakage, right? So remember that volume is getting drawn out of the intracellular space into the interstitial space. So as a result of that volume staying put within the area, what's going to happen? Remember, we said edema is going to occur. Edema is swelling. So if you're like, you're pregnant and your ankles swell, or you're old and you have the cankles, that's swelling. That's edema. Fluid wherever. Pulmonary edema, fluid in the lungs. Pedal edema, fluid in the feet and the ankles. Okay. So respiratory patients, or I'm sorry, burn patients that suffered an airway burn, they're going to need to be intubated because with that swelling that's going to be occurring, that airway can close off. So they get intubated pretty quickly. Someone having an allergic reaction. Oh, that's a different type of shock, but same thing. Somebody having an allergic reaction, what's happening in the throat?
It's closing.
It's closing.
It's closing again because of that leakage. So that's so that kind of edema, we call it laryngoedema because there's swelling going on in the throat, closing off the throat. Okay. All right. Well, I just told you then. All right. So yeah, exactly what I was telling you right now about anaphylactic shock. It is, like I said, what kind of shock?
Hypovolemic shock.
No, I mean, hypovolemic shock occurs, but what's the other one?
Distributive shock.
Distributive shock. It's a distribution issue. Because exactly what we said, the vasodilation, capillary permeability, we have leaking of fluid. Sorry. Beginning up early all week. All right. And so why do we give anaphylactic reactions epinephrine?
To dilate their blood vessels.
No, they're already dilated.
Oh, I mean to their bronchioles.
Well, not just the bronchioles, though.
The lungs?
Well, what's epinephrine going to do to the lungs and to the bronchioles?
Dilate the bronchioles open.
There you go. It's going to open up the bronchioles, allow more air to go in. But the alpha properties of epinephrine are going to cause the blood vessels to do what?
Constrict.
To constrict.
Yeah.
Right. So what's going to happen to that capillary permeability?
Decrease.
To decrease, to get the blood pressure back to normal. Okay. Okay. Another type of shock, and we're seeing it more and more nowadays, is septic shock. What kind of shock is septic shock?
Inflammatory.
Distributive.
It's a type of distributor shock. So, same thing happens here, where it's an infection that's going around the body within the blood. And so that infection, we're going back to what we've been talking about. The blood vessels dilate, the capillaries become permeable. Really, a lot of the vessels, but the capillaries become permeable, causing what?
To dilate.
Okay, they're dilated, they're permeable, lose blood or lose fluid into the interstitial space. So, are you starting to see the what you gonna call it? The theme here?
Yeah.
When we lose volume, we're losing the body's ability to deliver the oxygen. And as a result, because of the vasodilation, the volume does not change. And even worse, when the capillaries become permeable, we lose volume from the intracellular space. We lose it to the interstitial space, the area that between the cells. But that fluid is going to become, it's going to back up, causing swelling. As a result, your blood pressure drops, your systemic vascular resistance drops. So if I have an infection, which I did several years ago and I had to have surgery, What's your body's response to that infection?
It's gonna fight it.
I'm trying to find it.
It wants to fight it, right? So, are you going to see a fever?
Yes.
Yes. Um, what's the skin signs going to be?
Red, cold, and clammy.
Flush.
Be flushed and warm. Initially, remember that fever is going on. As it progresses, the skin can become mottled or pale, even blue. And now, because we're losing volume, what's going to happen to your heart rate?
Decrease.
It's gonna inc-
It's going to increase, right?
yes.
What's going to happen to your respiratory rate?
It's gonna increase.
Increase.
It's going to increase. And we've talked about those before, right? Tachycardia, tachypnea.
Yes.
Yeah.
Now, one of the signs of septic shock, which is different from the other types of shock, is the blood pressure drops. Okay? Your blood pressure is going to drop. So, as I was saying, shock or septic shock is becoming more common out there. And also, what pre-hospital can do. More and more EMS agencies are starting to implement sepsis protocols. So to be able to recognize the fact that the patient is septic, because just like the other types of shock, time is of the essence. So the earlier we can recognize it, the earlier they can start getting treatment. And some of those places are even carrying like what they call broad spectrum antibiotics, meaning they cover a bunch of different types of bacteria. So again, I'm septic. I got infection. I'm breathing fast. My pulse rate is elevated. My blood pressure is 90/50. What are you going to do for me? You do something that you guys were already taught and you guys got to do the last 2 days.
O2.
O2, how?
Non-rebreather.
Okay. What do you want me to do?
No, just in case someone comes, but I'll be here in a minute.
Okay.
I'm just gonna go drop some food to my, because I was gonna pick up at 9, but we forgot there was some monitoring. So now Michelle has to go and I have to wait.
Okay. Just leave the door open so I can hear the bell. So, yeah, you're going to put me on oxygen. How much oxygen?
15 liters.
15 liters via
Non-rebreather.
non-rebreather. What I want you guys to get into the habit with medications, and believe it or not, oxygen is considered a medication. What I want you to always remember is when you give me a medicine or a drug, give the drug, the dose, and the route.
The 5 rows.
What was that?
The 5 rows.
Fibroids? No. I mean, you'll do that before you administer it, but I mean, before the oxygen, it's kind of hard to mess it up in a way, kind of, sort of. No, I want you to give me the drug, the dose, and the route. Drug, O2, the dose, 15 liters. The route via non-rebreather mask. Or if you gave me oxygen via nasal cannula. O2 at 2 liters via nasal cannula. The drug dose and the route. If you assisted me with my nitro, assisted the patient with their own nitroglycerin, 0.4 milligrams sublingually. The drug, nitro, the dose, 0.4 milligrams, and the route,
Yeah.
sublingual. Okay. All right. So O2, 15 liters. Monitor. Other types of shock, you'll do a couple different things, but for this one, that's for the most part. Now, what if the infection, so with COVID going around right now, COVID-19, what else will you see with that septic patient?
Like side signs, or what do you mean?
So I have an upper respiratory infection. What are some of the signs and symptoms that you're going to see?
Cough.
A cough. What kind of cough?
Dry cough.
Wet. It'll be wet.
Wet because you have fluids in your lungs.
We call that productive. Productive versus non-productive. So non-productive is dry. There's nothing coming up when you cough.
Wouldn't it be ammonia?
What was that?
Wouldn't it be ammonia?
Pneumonia?
Yeah.
It can be. It can be a couple other things too, though. Not necessarily just ammonia.
Upper respiratory.
Yeah, just an infection, just the cough itself. If there's phlegm or green stuff, whatever, if there's junk coming up when you cough, that's what we call a productive cough. Productive cough. All right, we talked about a fever, right? What else? When you've had an upper respiratory infection, a cold or the flu, aren't those upper respiratory infections?
Yeah.
Yes.
And even lower respiratory. Okay, what else have you had? You've had fever. You've had a cough.
Sore throat.
Sore throat.
Sinus infection.
What was that?
Sinus infection.
Okay. What are you going
Runny
to get with
nose.
the sinus infection, though?
Runny nose.
Huh?
Or runny nose or stuffed nose.
Okay. Stuffy nose. The runny nose is sinus infection?
No, it's not. No.
No, other type of upper respiratory, you will get the runny nose.
Yeah.
So real quick on the sinus infection, you have an infection with the sinuses of the face. You have sinuses right up in here in the forehead, and you have sinuses right here in the maxilla. So one test you could do to check for sinusitis, that's inflammation of the sinuses, is you tap on the sinus. The patient complains of pain, it's sinusitis. Okay. The other thing is when you blow your nose and neon green junk comes out, good sign of sinusitis.
Yeah.
Or for a Spanish speaker, sinusitis. So I talked about chills.
What about flu?
Crackle.
What about fluid? What about the fluid in the ears? Does that consist with the sinuses or no?
No, but that can be discharged. But no, the ear pain is another sign of it.
It's an ear infection.
Yeah, it can be an ear infection.
Yeah.
Now, I can't say I've ever had a urinary tract infection, but what are some of the signs and symptoms of a urinary tract infection?
Fever.
Okay, so we're still with fever because of an infection. What else?
Sensation when you pee.
Increase urine output.
Okay, what were you saying, Sequoia?
Burning sensation when you pee.
Yep.
And it also has like a really like ammonia smell.
Okay. And higher up, you might have some abdominal pain.
Yeah.
Okay. Nursing homes are infamous for this. Having patients go to the hospital with urinary tract infections. Those patients usually have what they call a Foley catheter. In other words, they have a tube into the urethra that goes into their bladder. Anybody want to venture a guess as to why they would have an urinary tract infection, a
Because they
UTI?
don't clean it.
Okay, what was that, Miss Koya?
Fluid built up. It's your urine when you can't pee, that your urine like backs up, or yeah, it kind of backs up. So that's why they put a catheter in you.
What else can back up the urine though with a Foley catheter?
Well, it's not really protein. It's like the discharge of the waste.
Mm-hmm.
Along
Uric acid?
Yeah. Sometimes blood can be a obstruction too.
Okay. There's one more thing also. So that Foley catheter drains into a bag. It's all gravity fed. And so that bag needs to remain below the level of the patient. When it's higher than the patient, so here's a patient, the Foley bag needs to be down here so the tube gets it to go down into the bag via gravity. But when you raise that bag up, is gravity helping clear that tube and clear that urine from the bladder?
No.
No.
It's back flowing back into the bladder. So as Sequoia was saying, you have that backup that's causing that infection. So that's another reason why UTIs are very common at nursing homes, because your patient has a UTI, they have a Foley catheter in place, and it's not located correctly or placed correctly. So it causes the patient to have a UTI. Okay. All right, questions?
No.
All right.
No.
Have I drawn the picture of the brain, the spinal cord, and the electrical signals going down the spinal cord?
Yeah, I think
No. Wait, did he? I don't remember that.
Yeah, I think you did.
Did I talk about the line of demarcation?
I don't remember that.
Okay. Okay. Brain, spinal cord. Those are the electrical impulses within the brain, right? And so the impulses travel down the spinal cord until they go out to wherever they need to go. Okay. So brain, spinal cord, nerve comes out. We'll call this the brachial plexus, and that's a itty bitty hand. Okay. But Abraham got mad at me and he pushed me and I fell down the flight of stairs because I made him work way too much. Huh?
I said, God, Abraham, don't you know how to respect your elderlies?
Oh.
Hey.
Oh. Sounds old.
Just kidding.
It was a tough lesson.
Mhm. I think the class last night was ready to kill me. And I didn't really participate.
None of them?
No, I didn't participate.
Oh.
No, I had Paul and then I brought in Myra to help me so I could get some work done. Vienna, are you back? Hello? Somebody there?
It's a ghost.
Chris, when I heard the buzzer. Anyway. All right. So I fell down the stairs and who's there? All right, just a moment. I'll be right back, guys. All right, so I'm back. All right, so I fell down the stairs and Paul's like, "Come on, Lou, get up." And I say, "Oh, I can't. I can't move my legs." All right, here, give me your arms or give me your hand. I'll help you up. Oh, I can't lift up my hand. Okay. So what happened to the electrical impulse?
It was cut off.
There you go. So remember, normally the impulses are going down, but I suffered an injury right in there. So the impulses stop. Okay. No more impulse. Now, was my adrenaline pumping as I'm tumbling down the stairs?
Yes.
Yeah.
Yeah, right. Because I'm going to run back up there and I'm going to take care of business with Mr. Abraham. He'll learn what it's like to not be able to fly out of a second story window. So what are my vitals going to do? Remember, I have an adrenaline release, right? So where are my vitals, PR bells? What are they going to do?
The flight.
The what? The fight
Increase.
or flight response, right?
Yeah.
So tell me what my vital signs are going to do. Pulse, respiration, blood pressure, skin signs.
Increase pulse.
Okay.
Increase breathing.
Okay.
Dilated pupils.
Dilated pupils. Where'd you go, Rosie? All right, what else? Hi. Excuse me real quick while you guys think about it. Okay. So again, so my heart rate went up. What else?
Your pupils dilated.
My pupils dilated.
Blood pressure increases.
Okay. Blood pressure increases.
Go to the room. Go to the room. Put your ass in the room.
What was that?
Oh no, it's Arthur. There's the dog.
Get your ass in the room.
The dog. Just go.
What happened to my respiratory rate?
It increases.
Increase.
Increases.
Increase as well.
Okay. What's gonna happen to my skin signs?
They're gonna get sweaty.
Okay. Sweaty, pale. Pale, cold, dry, phoretic, right? So what system is the one that's kicking in?
Sympathetic.
Okay. So up here we have the sympathetic stimulation. Are those sympathetic stimulation, or is that sympathetic stimulation getting past this point?
No.
No.
So what's happening down here?
It's no motor response or anything like that.
Well, we already know no motor response.
It's not getting the signal.
It's not getting the sympathetic signal, right?
Yes.
So how do you think my skin signs are going to be?
They're gonna be pale, dry.
Not pale.
No, well,
Flush.
Oh,
Not necessarily flushed either.
what about dry though?
Sweaty.
Well, it'll be normal skin signs.
Normal.
Pink and dry. hate really slow computers. I can't find one. So what's going to happen is, again, we said the sympathetic stimulation above is going to be pale, cool, diaphoretic. We'll see the sympathetic response. However, below that injury, we're not going to see that response. And that's what we call the line of demarcation.
Yeah.
Because the area below the injury site didn't get the memo. All right, didn't get the memo to, hey, we're trying to run away or fight this guy off. So it's going to remain normal. It never got the message, so it's going to remain normal. And you can see on the body what they call the line of demarcation. Above will be pale, cool, diaphoretic, and below that will be pink. Will be warm and dry. Okay. So that's the line of demarcation lecture.
What was the bottom was warm, pink, and dry. What was above?
Well, it's gonna be pale, cold, diaphoretic. Because remember, above the injury site, it's getting the sympathetic stimulation, whereas below the injury site, it is not. Okay. So everything that you have that we've been talking about with that vasodilation, or I'm sorry. Now, the other thing with neurogenic shock also is, if you have damage to the spinal cord itself, and let's say it's not even a severing of the spinal cord where there's no message, but normally what's happening to the spinal cord is the blood vessels, instead of constricting, they're dilating. And so again, it all depends on where on the spine the injury is. But we can also, as we've been talking about, with the vasodilation, decrease in preload, decrease in systemic vascular resistance. So we can have a couple different things going on, okay? A good severing in the spinal cord will have that line demarcation, or have normal below and abnormal above. We could have trauma to the spine, where we lose the tone, the vascular tone. So they dilate, decrease in volume. Okay. So the main thing we're going to do with neurogenic shock.
Not having it yet. Looks like break.
Howdy. You're here but not here? All right. And the last one is cardiogenic shock, and we talked about how it originates in the heart.
Yes.
Okay. I talked about a heart attack, an MI, myocardial infarction. It damages the heart muscle, so it's no longer able to pump effectively. Along the same line, an MI can cause heart failure, but age can also cause heart failure, and that's another cause of cardiogenic shock, is failure of the heart to pump adequately, to empty itself out.
Is it also like if you have like a certain disease too along with the heart?
You talking about like some sort of congenital defect?
Yeah.
COPD.
Yeah. What was that, Rosie?
Nothing.
Somebody else was saying something, I didn't catch it. Okay. So yeah, congenital heart defect where it's affecting the heart's ability to pump. We'll do it. Another thing would be an abnormal cardiac rhythm. In other words, the electrical activity of the heart. It's disrupted. There's something wrong with it. So it's not delivering the shocks appropriately to the heart. And therefore, the heart's not going to react accordingly. A good example will be there's a heart rhythm called a third-degree heart block.
Oh, the what?
Which was that?
What is it called?
A third-degree heart block. What happens with a third-degree heart block is that there's no communication between the atrial ventricles. So in other words, take an old married couple or a young married couple or a old dating couple, whatever. You know, you've been dating more than 2-3 years and you get pissed off at each other, right? We've never been through that, right?
No, we have.
No.
And you're just so mad at each other that you don't talk. You do your own thing, he or she does their own thing, but you never talk to both do the same thing at the same time, right? To get along.
Yeah.
Well, that's what's happening in the third-degree heart block. Is that the atria are just off doing their own thing, the ventricles are off doing their own thing, and what do you think is happening to the amount of blood going into the ventricles and then going out of the ventricles? It's not getting enough volume. And so the ventricles aren't filling up and sending the blood out. They might be only halfway full.
Communicating.
Yeah, there's no communication going on. Isn't the problem with most couples and ex-couples? There's no communication.
You weren't.
Well,
Yeah.
Michelle's laughing at me. She's heard me. Well, it's true. Michelle's laughing at me for that analogy. But no, that's the best way we describe a third-degree heart block. And so really what the heart needs is a mediator. That's what a pacemaker is. It mediates the two so that they're doing what they need to do. So cardiogenic shocks originate in the heart. So electrical problem or drug use. Man, Aaron's flipping me off. I just see him put his middle finger on the camera and he's moving it around.
Oh no, it's because the freaking low battery keeps coming up, so I keep pressing it. That's
Okay.
Yeah.
So drug use. One of the biggest ones that does cause heart problems is cocaine. Cocaine is a very potent, very strong vasoconstrictor. Constricts the blood vessels. So people have been known to die from heart attacks after taking cocaine once. So drug use can cause heart problems as well. So just remember, cardiogenic, it originates in the heart. It's a heart pump problem for some reason. Not enough blood, failure of the heart muscle, irregular conduction, or some sort of illegal drug that's causing the heart. Actually, it doesn't even need to be illegal. It could be any drug. They overdose on a drug.
That's
Cause-
why Miss former lady Reagan said don't do drugs.
Oh yeah. So the main thing that we're going to worry about with cardiogenic shock is the ABCs, maybe give them some oxygen, but not much else that we could do as EMTs for that. Paramedics can, but EMTs, there's not much we could do. Okay. All right. Let's see. Give me back my mouse. All right. What's the term that best describes the type of shock that occurs when there is massive systemic vasodilation? Is it obstructive, metabolic, distributive, or cardiogenic?
Obstruct.
Metabolic.
Distributed.
Let's see, I heard distributive.
I mean, it is distributive.
Well, I gotta find my mouse first. Holy cow, this computer is so freaking slow. And it is. Okay. Okay. Body's response to shock. Let's take a break now, and then we'll move on from here. Okay. Be back at 10 o'clock.
Yeah, that's fine.
Yeah.
All right. I'll
Sounds
see you back.
good.